No, I was saying that because you were worried about people missing the session, I was saying that we will be recording it, so anybody who misses the session will still have access to it.
All right, no problem. Okay, thank you very much. So thank you for the opportunity. I will go straight ahead with the presentation. So, good morning once again. My name is Dr. Sheila Appiah-Pippim, and I'm a psychiatrist at Korle-Bu Teaching Hospital. So today I'll be talking about schizophrenia. And like I said, I'll be using about 20 minutes for this. Try to simplify it as much as possible. Is my screen moving? I think I'm having some technical challenges. Please, is my screen moving?
No. Okay, it just moved. Do you want us to share from our end or?
No, it's all right.
Okay, sure.
So by way, oh, I think the screen sharing has gone back to. All right. So this is the outline. We look at the introduction. We look at some few definitions, epidemiology. Then we look at the etiology or predisposing or risk factors. We look at the diagnostic criteria, which includes the signs and symptoms. Look at the types of schizophrenia, management approach, and then the conclusion. So this is more like my favorite picture that describes mental health. And in there are a lot of mentions. So this is the brain, and in there we have a lot of things: emotions, sensory functions, psychological issues, depression, anxiety, stress, personality disorders, substance use, coping mechanism, wellness. Everything is in there in the brain. So the brain is a very powerful organ. Now, I always want to mention that psychiatry is a medical specialty. Therefore, this is a medical specialty. Disorders pertaining to psychiatry are managed mostly with medications. It is a medical specialty concerned with mental symptoms caused by disorders of the brain and mind. So it's predominantly disorders of brain function. So most of the time, when individuals have mental health challenges or psychiatric disorders, they want evidence, they want proof, they want a lab finding, they want a CT scan finding, MRI, evidence that this is a disorder. Most of the time, you wouldn't find anything because it is a disorder of the function of the brain, which is the mind. And it is very difficult to measure the function of the mind. So we use a constellation of symptoms and signs, deviation from normal behavior, which are social, like out of keeping of the social and cultural context. And we use that to diagnose. So we have the Diagnostic Statistical Manual 5, DSM-5, from the American Psychiatric Association for the America, and then the International Classification of Diseases 11, ICD-11, which is developed by the World Health Organization. So schizophrenia is part of the psychiatric disorders that we have, and it's a major mental health condition of great public health importance. Now, we can't go on without defining what health and mental health is. Health, according to the World Health Organization, is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So ingrained in the definition of health is mental health. Because most of the time, people think that if you are unwell, if you have ill health, then we have to see something physical. We have to see a broken limb. We have to see that you are, not able to move, or you are not able to function. Like you physically, we have to see something. We have to see a bruise. We have to see that you have a fever, infection, but it is not only the physical that we're looking at, but it's a state of complete physical, mental, and social well-being, and not just absence of disease or infirmity, or like maybe you have an amputation or something like that. So mental health is a state of well-being, a state of health in which every individual is able to realize his or her own potential, can cope with the normal stresses of life, and can work productively and fruitfully, and is able to make a contribution to her or his community. So all these parameters must be present to have a good mental health. Sometimes it's like a chicken and egg situation. Your ability to work productively and fruitfully is an index of your mental health. But most of the time, if you are mentally ill, it may affect your productivity and fruitfulness. Or it could mean that your inability to work productively and fruitfully is because you have a mental health challenge, or it is a sign that you have a mental health challenge. And if you're unable to cope with the normal stresses of life, it could be that you're having mental health challenges. Okay, so all these criteria have to be fulfilled. Now, schizophrenia, it's difficult to define schizophrenia. So we just say, what is it? So this is from the ICD-11, okay, and it actually summarizes what schizophrenia is. And I will go into details when we get to the signs and symptoms of diagnostic criteria. So it is a mental health condition characterized by disturbances in multiple mental modalities. So multiple mental modalities, including thinking. So the way you think. So you may have delusions. Delusions are false beliefs that are fixed and they are held on to despite evidence, contradictive evidence, and these are out of keeping with the person's normal social, cultural values or beliefs. Okay, so individuals with schizophrenia may have delusions, may have disorganized form of thought thinking, and then they have perceptual disturbances. Now, perception is a response to a sensory stimulus. So we have 5 senses. So we normally will receive a stimulus. You see something. It records in the brain, and you're able to see that this is a pen, this is a book, or this is somebody standing there. But there are instances where there are false responses to sensory stimulus, okay? False sensory perception, and that is the hallucination. So you are seeing something, you're seeing someone standing there, and nobody else can see it. You are the only one who's seeing it. So it's a false sensory perception. You are hearing voices through your ears, auditory hallucination. You are the only one hearing it. Or you feel like things are creeping on your skin when there is nothing. So then you have tactile hallucination, so the touch. Or you're tasting abnormal, taste in your mouth, although there's no food. Or even if there's food, maybe it could be that you are tasting it differently. And all these are hallucinations called gustatory. And then olfactory, you may be smelling something. Other people are not smelling it. Only you, all the time, you are smelling abnormal stuff in the room. It could be an olfactory hallucination, okay? So there are disturbances in self-experiences where the individual experience feelings that one's feelings, impulses, thoughts, or behavior are under the control of an external force. We'll go into detail when we get to the signs and symptoms. And cognition, it could be impaired attention, verbal memory, social cognition, volition, affect, that's emotional responses, behavior. You can have bizarre behavior, okay? Can be destructive, moving from place to place, and they may have disorganized behavior, or we call abnormal behavior. There can be psychomotor disturbance, including catatonia. So we'll explain all in details, okay? And you can have persistent hallucinations and all that. All right. So we'll go on. What is the burden? What is the epidemiology of schizophrenia? Worldwide, mental health disorders affects more than 1 billion people. And this was a study done 2019. And this was recorded in 2016, like in retrospective studies and all that. And mental health challenges cause 7% of all global burden of diseases. 7% is a big figure. Even 1% is something, you know, to be worried about. Now, the Global Burden Disease Scale 2017, what they do is that they look at various countries all over and look at the burden of diseases. And they have measures. They use years of life lived with the disease, with disability, and years of life lost to the disease, like death. So they look at morbidity, mortality ratio, and they use to calculate the global burden of disease. Schizophrenia was found to affect 0.2% of every population. Okay, and major depression ranks highest because it is the leading cause of disability worldwide now. However, schizophrenia is also very significant. Although the other mood disorders also are like catching up, and substance abuse and all that. Schizophrenia is also of major concern, 0.2% the global burden of diseases. What causes schizophrenia? It is very difficult to tell. The exact cause of schizophrenia is unknown. However, there have been postulations, there have been theories to actually find out what could be the problem that causes schizophrenia. So there have been various studies that have shown that there are imbalances in the chemicals in our brain. These are neurochemicals. So we have dopamine, we have glutamine, we have serotonin, we have adrenaline, we have GABA, okay, gamma aminobutyric acid. These are all that help to regulate a lot of things, our ability to have the energy to do our activities, okay, your ability to sleep at night, your ability to work, to know when to talk, when not to talk, to be inhibited, to know, yes, when to discuss issues in public, and all that. All these things are regulated by chemicals, okay? Our emotions, whether we feel happy, sad, angry, or decide not to talk to anyone or interact with people, all these are controlled by chemicals in our brain. And it has to be balanced. It's a balance between all these chemicals. So that theory found out that people with schizophrenia may have dopamine overactivity. That means they have high levels of dopamine. And this was evidenced by the fact that the antipsychotics that are used in the management of schizophrenia work on these dopamine receptors to block it, so that this excess dopamine doesn't get to act on the receptors, and they are broken down, and then they go out of, you know, the bloodstream, okay? And it also realized that it could be that glutamine is hypoactive. It could mean that serotonin is overactive. All these things are evidenced by medication trials, where they realize that if it is working, if this antipsychotic is working, then it means that there was a dysfunction in these chemicals. That is why it is regulating them. And it forms the basis for using medications in the management of schizophrenia. So what are the predisposing or risk factors? Genetics runs through most of these mental health conditions and has a heritability of between 60 to 80. We'll go into details to find out how one can be predisposed if they have a family member or a relation living with schizophrenia. Some postulated environmental risk factors include complications, pregnancy, delivery, neonatal complications. So when you come to the clinic, most of the time, when we are taking the history, we go back to all these. If we have your mother around or a parent around, we go back and explore whether something could have happened during the antenatal period, the postpartum period, and all that. Okay, neurodevelopmental difficulties, delay in walking, disturbed childhood behavior. So it is important that we also observe our children, growing up. Any disturbed childhood behavior can be a red flag. It can actually herald a mental health challenge. I always give this as an example, but I am not too proud of it. It is quite, sentimental for me. But way back in primary school, I had a classmate who used to have, all of a sudden, she had this awkward behavior of developing a fit, a seizure, whenever she was about to be caned, like she was about to be lashed. The teacher may be lashing all of us, and those were the times that they were lashing us, for trivial issues. Teacher comes to class, says that I wrote something on the board before the bell rang, and then she wiped it. So what did I write? Nobody answers. And then she says that I'm going to beat you all because of that, and starts, lashing us. And when it was this lady's turn, the cane hadn't gotten to her. It's just like she just fell, she jagged, she was rolling her eyes, she started drooling saliva. And it happened again. Whenever they're about to lash her, then she'll behave that way. Then they call her parents, they take her home, they'll take her to the sick bed, they'll take her to the hospital. She comes back, and it continued. And she didn't really have, I'm told she didn't have any epilepsy. They did all the checks. But little did I know that was the beginning of her mental health challenges. And years on, in 2017, when I was doing residency, I went to my ward and they mentioned the name and said that this person was on admission. And then I was like, oh, wow, it has to be this person because she has that peculiar name, and lo and behold, she was the one. And she was very tearful and all that. And I realized that the problem had started even when we were in primary school. And I think it was diagnosed when she was in secondary school. So she was diagnosed with schizophrenia. And I realized that this could have been like a herald, and it was missed because it was overly spiritualized for her family. So it is important that when you have any disturbed childhood behavior, we need to quickly, get mental health services, not delay until you have a florid psychosis, a full-blown psychosis. Severe maternal malnutrition has also been associated with a risk factor for schizophrenia. So mothers, pregnant women have to make sure that they eat well, healthy, and all that. Degree of urbanization, this was in relation to all the social drift stories that said that people living in the rural areas or even urban areas were more predisposed and people moving a whole lot. But all these theories have been debunked because it can happen anywhere that you are. The use of cannabis, especially during adolescence, and that is the period that the adolescents actually experiment with drugs. So if you have a predisposing factor, like a genetic risk factor, and you start using cannabis very early, then you are actually setting yourself up for future mental health challenges like schizophrenia. So this is a table describing the predisposing factors, genetic risk. So if you have a family member, if you are an identical twin and your identical twin has schizophrenia, then you have a 46% chance risk that you may develop schizophrenia. Okay, and if you have both parents living with schizophrenia, then the children, the offspring, each has a 40% risk of developing schizophrenia, which is why I think in the past, before people go and marry, they look into their families, look into the history to see whether you have any family history of a mental health challenge. They don't want it to actually propagate, be passed on to children. But schizophrenia carries a high heredity a risk. So if you have a sibling or a fraternal twin or one parent having schizophrenia, then you have a 12 to 15% risk of having schizophrenia. And if you have one grandparent living with schizophrenia, you may have a 6% risk of having schizophrenia. If you have no relatives affected, so sporadically, 0.5 to 1% risk of having schizophrenia. And all these things are probabilities, they are chances. So sometimes it can skip generations. You see people, an identical twin, and the other one is fine, going about their activities, not having any mental health condition at all. Or you can have one parent and still none of the offsprings will be affected. So let's not be scared, but these are research findings and they are still probability, risk. So schizophrenia and details, what are the signs and symptoms? So as I mentioned, I'm going to actually expand on it now. So individuals may have auditory hallucinations, and the auditory hallucinations are in the third person. So the individual hears voices referring to him as he, and they may run commentary on the individual, just like how the football commentators run commentary on their football players. So for instance, with the activities, if they are running commentary, the individual hears the voices as he is going to bath, he is going to sleep. They actually comment on all the activities, almost all the activities, okay? And this individual hears that alone. No one else hears it, even when they are alone in the room, okay? And they may hear the voices arguing about them. So for instance, I had a client who had multiple auditory hallucinations where she was hearing three voices. One said, she's a good girl. One said, she's a bad girl. One said, she's neither good or bad. And she's hearing all these three voices. It was very distressing to her. Okay. However, she improved on injections and medications. So the individual may have third person auditory hallucination, running commentary, voices arguing amongst themselves about the individual. They hear their voices, their thoughts being spoken out loud. So that's what we call the thought echo. So for instance, I had a lecturer I saw in the Upper West region, I think during one of my basic needs, outreaches, for mental health. And this lecturer was waiting to see me in the consulting room. And so whilst he was in the waiting area, he said a few thoughts came into his mind and he just wanted it to go away. So he said it in his mind, go away. Before long, he could hear the voices repeating, go away, through his ears. And there was no one around. And he realized that nobody sitting around was actually opening their mouth. So he realized it was the voices that were echoing his thoughts, although he hadn't disclosed what he was thinking in his mind to anyone. So there can be thought echo. There can also be commanding auditory hallucination, and this can be very distressing. And, I've had lots of clients come with commanding auditory hallucinations. So for instance, I had a gentleman who was referred by the urology team because he had slit his scrotum. And when I went to him, he said he had been hearing voices for 5 years and voices commanding him to do a lot of things. The last straw was when they asked him to cut off his penis, and they threatened that if he didn't do it, they were going to do it for him. And so he said that for them to do it, he would rather do it because he was unsure of how they were going to do it. So voices led him to the bush. He picked some broken bottles and luckily for him, he slits his scrotum and not the shaft of the penis, not the penis. So I think when he started bleeding, then he realized that, what have I done? And passers-by helped him to the hospital. They stabilized him and they referred him to Korle-Bu. And then the urology team went in and all that, sutured and stabilized him and then asked us to come in. So yes, it can be very distressing to have auditory hallucination. And that is the auditory hallucination with schizophrenia. They have delusions of thought interference. So for instance, they may think that their thoughts are being broadcasted everywhere. They are the topic on the radio, TV, their thoughts, what they are thinking, although they have not disclosed to anyone. These thoughts are all over. People know what they are thinking. And it's not telepathy, like their information is all over, you know. So they become very suspicious, okay? They also may feel that their thoughts are being interfered, in that people, like external forces, are taking thoughts out of their mind or inserting thoughts into their mind, such that the thoughts that they have do not belong to them, but belong to an external force. They may also have delusions of control. So for instance, they may think that, they may believe that their emotions are under control of an external force, their volition, their ability to act, to do anything, okay, their movements was also under control. So a typical example is like yesterday, I had a client in my consulting room who believed that she was being controlled, in that she felt like her back is being pushed. And it was a bit awkward. Yeah, she feels like some people are having intercourse behind her, at her back, like, and all that. I mean, it was quite bizarre. And they shake her. So she's not having intercourse with anyone. She's alone. She sleeps alone. She's single. And she's shaking. And she thinks that some external forces are having sexual intercourse with her. And that's causing her to jerk. I also had another client who burst out in laughter when she's in a meeting and all that. And she was not even aware that she was doing that. So it took her HR to actually recommend that she comes to see me. And she told me that it's very embarrassing for her because she's not under control of this. And she's not happy at the time that she's laughing. She just burst out laughing. And then it stops and she can't control it. And it's very embarrassing. Like, people are discussing serious issues at a conference. And she's in there. And then she just burst out laughing. And then everybody looks at her and she doesn't know how she laughed. So she was being controlled, okay? And we have delusional perception. So you see something correctly and you form a delusion out of it. So a typical example, I'm using examples so that it becomes more applicable to you. Typical example is a client that I had who saw a banner in not even in her church. She had visited a church with her mother and she saw a banner and she said that that banner implied that her promotion was due. So implied that her promotion was due. So she had gone to her employer to insist that her promotion is due, so she should be promoted. And they were confused, like, who told you that your promotion is, you've not done any appraisals, you've not done any, interviews, what are you talking about? And she insisted that she was going to send them, to court if they don't promote her. And she said the evidence is in that church and the banner. And her mother said, no, that banner was advertising a harvest and that is not even your church. So how is that related to you? She said, no. This is an indication that my promotion is due. So she had held on to it. And because of that, she even resigned. So she formed a delusion out of a normal perception. And they may have negative symptoms. And the negative symptoms are, apathy, you don't want to do anything, you are not motivated, affect glands and all that. And all these things must go on for more than 1 month. And it must not be due to any other medical condition, like a brain tumor. It must not be due to substance abuse. It must not be due to withdrawal from medications or caused by any medications, okay, before we diagnose schizophrenia. So here we have the positive symptoms and the negative symptoms. The positive symptoms are what I have mentioned: delusions, hallucinations, formal thought disorders, okay? And then we have the negative symptoms, okay? Evolution, not motivated, loss of awareness of socially appropriate behavior, social withdrawal, okay? Blunted mood, affects poverty of thought and speech, mutism, all those things are negative symptoms. So these are the types of schizophrenia. And they have moved away from trying to describe the types because they feel like it does not really help in the management. It does not really change the management approach. So that nobody thinks that one is a better option than the other. But we have paranoid schizophrenia where the individual have paranoid symptoms. They feel like they are being persecuted. They feel like someone is after them. The typical example, they may feel like, their rooms are being invaded. This individual I saw yesterday had to change her lock 3 times, although she was living alone. Every time she felt like her room was invaded, and she didn't have any evidence, but she believes that somebody comes into her room when she goes to work. She's a nurse, so she had to change her lock 3 times, and each time she changes her lock, still she feels like somebody has come to sleep on the bed. So I was like, are you sure you laid your bed before going? She said, yes, I laid my bed. When I come back, it's crumpled. Somebody has come into my room. How did they get access? I don't know. So I had to change my lock 3 times, and it didn't work. So she had to move from that apartment to another place, and it continued there. And the last resort was for her to move from that city, move away Accra from that city, come back to Accra, stop working, because she couldn't come to terms with, feeling that people are after her and all that. So I start her on medication. I pray she takes them, and I encourage her to take it. Hopefully I see her in 2 weeks. Hebephrenic schizophrenia is also called the disorganized type, where the individual have disorganized speech, behavior, or inappropriate emotional responses. Catatonic schizophrenia, where they have psychomotor disturbances, so they may become stiff mute, they'll stare blankly. You talk to them, they are not responding, they are not speaking. They become like wax. Sometimes they assume postures. You can even bend their hand and they wouldn't feel anything, they wouldn't make any sound. So all that is catatonia. Okay, and they can blink continuously, stare blankly, or they can mimic your behavior, and that's what echoprasia. They can mimic your speech as echolalia. So you say, yesterday I went to, then you also, yesterday I went. They are repeating everything that you say, and that is a feature of catatonic schizophrenia. The undifferentiated type, self-explanatory. We can't really tell whether it's paranoid, hebephrenic, or catatonia. And post-schizophrenic depression is that you've had schizophrenia and you have recovered, but you may have some residual symptoms. But now you are presenting with depressive picture. Okay, symptoms of depression. Residual schizophrenia, previously having a positive symptoms, like I mentioned, delusions, hallucinations, which are less marked, but now you're having prominent negative symptoms. And simple schizophrenia, you may not find any delusions or hallucinations, but you may have negative symptoms, like a young man that I saw who had moved all the way from the US. He got a scholarship for university in the US, and one day he just came. He did unannounced. He picked the plane, came to Ghana, had packed all his things, and came to his parents that he was not going back. And his parents were worried, like, whoa, what's happening? You're on a scholarship, you're in second year. He didn't inform anyone. He was just at their door. Luckily, they were home. So I realized that he didn't have any delusions. He didn't have hallucinations. He denied all this, but he had just lost interest in everything. Socially withdrawn, will be in the room, don't mind anyone. Okay, so that is simple schizophrenia for you. So how do we manage schizophrenia? So in the acute phase, there may be a lot of agitation. So there's the need to admit and observe and carry out investigation. So like I said, we need to rule out any other causes of, any other organic, any other things that may cause problems. So we have a biopsychosocial approach. We do biological investigations. We do a scan to rule out maybe any brain tumor or anything. We have to do an EEG sometimes to rule out epilepsy, because epilepsy actually has a theme wall, shares a theme wall with psychiatry. We need to do labs, investigations. We need to check your thyroid function and other investigations that may be carried out. In psychological investigations, psychosocial, we have to look at all the risk factors. What are the stresses? Why is this person having this at this time? Okay, so part of the investigation for biological too, you have to do a urine for substance screen to rule out any substance abuse. And then we go on to the treatment. That's also biopsychosocial. Most of the time, antipsychotics are the main modalities for treatment. And second generation antipsychotics. Second generation antipsychotics are now in use. So these are the medications. I'm sure that you may be familiar with some of them. Olanzapine, risperidone, paliperidone at effective doses. Okay, the first generation ones, we are trying to move away, but when it's really indicated, we give. In the absence of the second generation, we can give that. Or if the individual has diabetes that is poorly controlled, we may move to the first generations like haloperidol, chlorpromazine, and all. Sometimes diazepam is used to manage agitation in the acute phases. So for maintenance, we actually optimize the second generation. And individuals with schizophrenia may have poor insight, as in they don't believe that they have a problem. So then we may need to give long-acting antipsychotic injections, which are depots, that releases the antipsychotics in actually minimal doses every day for at most a month. And it's out of the system, and the individual has to top up. So we have monthly long-acting injections. So we have the IM Invega Sustainer, we have the IM Modicates, we have the Depixol, we have haloperidol, decanoate. So in conclusion, we should know that schizophrenia actually can occur throughout the life cycle, although the research has shown that the onset is usually in the adolescence. But we can have late onset, people coming in their 60s who have never had schizophrenia growing up in their adolescence or childhood, and then they develop schizophrenia after 60. And it is multifactorial. The exact cause is unknown, but there have been theories around it. And the management approach is biopsychosocial. I forgot to tell you that even in the treatment, we employ psychotherapy. You need to see a clinical psychologist, do insight-oriented therapy. You need to educate the family, have family therapy. We can also do occupational therapy, because individuals have to be rehabilitated. Sometimes long periods of having schizophrenia affects the individual's cognition and all that. So elsewhere, there may be specialized jobs for people living with schizophrenia who are stable but are not able to perform their roles at that cognitive level. So they have specialized jobs for them. So all these come into play when we are managing schizophrenia. Schizophrenia, when untreated, runs a very chronic deteriorating course, and it causes a lot of public health burden, because you end up, the individual ends up depending on parents. They can't work, so they are not productive, their lives, come to a standstill. Quality of life is poor, it has issues with, marriage, having children, and all that. So it is important that we are aware of schizophrenia. Thank you very much. These are my references. Yeah, thank you.
Thank you, Doc. So we'll have the question and answer session now. So I'm just going to reiterate Doc's bio for all of us to know her, achievements and her expertise. So she's Dr. Sheila Appiah-Pippim, a specialist psychiatrist at the Korle-Bu Teaching Hospital. She's a member of the West African College of Physicians, Faculty of Psychiatry, as well as a member of the Ghana College of Physicians and Surgeons. She's a part-time lecturer with the University of Ghana Medical School. Dr. obtained her medical degree from the School of Medical Sciences at KNUST in 2011. She runs mental health clinics on part-time basis with two of Ghana's premier private hospitals, the Cocoa and Trust Hospitals. She's currently pursuing a fellowship in neuropsychiatry with the West African College of Physicians. She has been in the mental health space for almost a decade. So today she brought all of that experience to bear in this presentation. So if any questions came up to us while she was speaking, kindly share them in the chat, or you can raise your hand so that we give you the opportunity to speak on the mic. We're very grateful to have had Doc with us today. And we're also grateful to have her continue to stay and then answer any questions that we might have. So I think there's a question in the chat that says, can hebephrenic schizophrenia be treated?
Okay, thank you for your question. Schizophrenia is actually a chronic mental health condition. So it is managed. You don't use treated, because if you say treated, then we are looking at infectious diseases and all that, and like you have malaria and take medications 3 days, you are treated. However, that is not how schizophrenia is. It's runs a chronic course. So we manage. So most of the time, individuals have to be on medications for a long time, even not if not for life. Okay, so it can be managed, but pinpoint treatment is a big thing. So it can be managed. So there are a lot of schools of thoughts on how long individuals should be on medications for schizophrenia, and some research have shown that you need a minimum of 5 years. Some also have said that you don't stop it. It's for life, because it's a neurodegenerative disorder where the neurons are already affected. So what has been done cannot be undone. You can't go back and actually reform all these neurons that you may have lost due to schizophrenia. So you need to continue managing with the antipsychotics. So that's the bit that I can say about it. So it can be managed, but treatment is a big word. All right, thank you.
Thank you, Doc. So someone has two questions. Someone says, okay, so I think it's two questions in a scenario. They said they knew someone that's the person never showed any signs of schizophrenia till adulthood. And so they want to know if something can trigger it in someone that is dormant. And then they also want to know what to do in the situation where the schizophrenia causes the person not to trust anyone. So those trying to help are being pushed away or being doubted.
Yes, good. Thank you. For the first part of the question, I mentioned that schizophrenia can occur anywhere along the life cycle. So some may start. The normal trend is that it starts in the adolescence, but there are individuals who develop it late, their 60s, and all that. Okay. And like, if you have a genetic predisposing factor, then you have the chance of getting it. And for all the mental health conditions, you need a trigger, stressful trigger. This could be substance, either cannabis, any other substance abuse. It could be any stressful life events, negative life events, trauma. All these things can actually trigger a mental health challenge. And sometimes it's very difficult to tease out. You may be tempted to explain it that, oh, it's because the person lost a loved one. That's why this, but It's not everybody who loses a loved one who develops a mental health challenge. You get it? So for somebody to get it means that they may have a genetic predisposing factor. They just needed a stressful trigger to actually exhibit the signs and symptoms. Now, for the second part, that individual may have paranoid schizophrenia. And when it happens like that, you should find just one person that the person trusts or the person reverse, like will listen to. Sometimes, we are a very religious nation, so maybe you can use a religious person to talk to the person and get the person to see psychiatrist. And some of the churches, I believe, are doing that. They actually they will tell you that they are doing the spiritual side. So you go and get medication. Some of the churches do that. They send you. Some too would hold you and manage spiritually. So it's a very dicey situation, but you should be able to get the person to a mental health facility. If the individual is adamant, even upon persuasion and all that, using all your decorum and all that, and it fails, then if you realize that the individual is at risk of harm to himself and people around, then you can actually, get to procure a court-ordered treatment, so that we can mandate the individual to get to a psychiatric hospital and get managed. And nobody's above the law. So once the court has issued, a report, an order that you should get help, then you get help. But before then, a psychiatrist has to examine the person. And now we have a lot of community services, people coming into your homes, as in mental health nurses, psychiatrists. Some psychiatrists do home visits. They can do that, assess, get a report that you attach to your own, letter to the court that you want your ward or your relative or whoever to get mental health care because of A, B, and C. Okay, and then we follow up from there. All right. Thank you.
Thank you, Doc. Okay, so there's a question about if schizophrenia can affect you physically. There's another one about what age a child can be diagnosed.
Okay, so schizophrenia affects you mentally, but you know that mentally is related to physical. So if you are not taking care, people have schizophrenia and they are not taking care of themselves, like poor self-care. They wouldn't bath, they wouldn't clean, they wouldn't eat well. I mean, they are paranoid, they wouldn't eat from the home. They may be hearing voices that are telling them to eat things inedible, things, all that. And all these things can affect your physical health. You see, so that if you are even ill, physically ill, you don't even have the mindset to actually go for help. But when you are managed on medications, all these things will just go away. But untreated schizophrenia, long periods untreated, all causes all these challenges. At what age can schizophrenia usually, the onset from the researchers in the adolescents. So you see people around 14, 15, 16, typical age around 16. So maybe, like I said, the secondary school time, but you can have it earlier. I've had people like 12 years, 11 years having schizophrenia. So we say childhood schizophrenia. But the typical age from the research is usually around 16 years of age. Okay, other questions?
Okay, so someone is asking about how to get an older person. The person said their mother who is in her 60s is showing signs, but doesn't believe there's anything wrong. So the person wants to know.
I think I've answered that one about using decorum, using, people that your mother really respects and can't actually say no to. Okay.
Yeah.
And you need to do it in a nice way so that they don't feel like they are being punished. They actually don't feel extra paranoid. Okay. And now we have mental health services in private hospitals, and general hospitals. So you can actually mention to her that want you to, get checked, to see a doctor. And then you are going to a general hospital, not a psychiatric hospital, so that the stigma is there, so that she's not extra vigilant. Okay. If all those things fail, she's not even ready to get help in a general hospital or private hospital, then you can use the court approach. You say when persuasion fails, force must be applied. So that is the way to go. And the Mental Health Act, the Mental Health Law permits all this, like getting a court order, all that.
Yeah. Okay, so we're almost out of time. But someone has their hand up. I think they want to ask a question on the mic. Olubi, please, you can go ahead and ask your question.
Yes, thank you very much, Doctor.
Thank you.
Good afternoon. Thank you very much for a beautiful and concise presentation. I hope you can hear me.
Yes, we can hear you.
Yes, I just wondered, I would like to make a comment and perhaps have your, maybe you get a response. In Africa, we all know, I am doctor, I'm a medical doctor, so I understand a lot of what you're saying. Now,
Okay.
one of the issues we have, which I would like, is a lot of denial, especially in the early stages in our society about mental illness. Schizophrenia is quite common. Sometimes it's mild, and a few people are able to cope. Sometimes without drugs, but you can tell that there's something wrong with this person. And sometimes it progresses, and before you know it, this person can no longer function. When you suggest to the family members, take this person to see a doctor, they say no, it's not my portion. We're a very religious society. It's not my portion, or well, no, what's the big deal? Until that person now. I will tell you a very unfortunate personal event that I had. This was somebody who obviously was ill. And I remember I used to tell my friends, my colleagues, this person is unwell. But I don't know, people didn't pay too much attention. I think she eventually got some help, but I'm not sure the family ensured that she got enough, because eventually she ended up, she was living with her mother. One day she killed her mother.
Oh.
This is so unfortunate. It's and I believe that if she had gotten help at the time, and we had people who were there to ensure that she had continued with her medication, it is unlikely that unfortunate thing would have happened. So I think that's a problem in our society. We are so much into faith. I'm not saying faith is bad. No, I'm not saying that. But we're so much into that we generally live in denial for quite a while, until many times it's often too late. Thank you.
You're welcome. Thank you for your comments.
Thank you.
So it's all about sensitization, primary prevention through education. So what Silent Scream Foundation is doing is excellent. I mean, it's a step in the right direction. So every corner you are in, everywhere, you have to actually make sure that we get to educate people, because you'll be surprised. You think that but they may not know that there is help medical help for these conditions. So thank you very much.
Thank you, Doc. Thank you, everybody, for joining us today. We hope
Are
that
we done?
yes, please, we're almost done.
Oh,
Please, did you
I'd
want to
wanted
add?
to chip in something.
Oh, okay. No problem. Please go
I
ahead.
remember many years ago when I was working in an office, now I'm a pastor, and we had this boss, a female boss, who would ask us to render some kind of service. And she will call, Rose, can you please do this for me? Then after some few minutes, you come back and say, never mind, don't do it, stop. And you see her doing that thing herself. Then we were wondering what's happening. She would ask us to do something and she would go back and do it. She will go out and come back to the office and she will stand and look at her chair and turn it and wipe it, clean it before she sits down. She thinks somebody may have, put something on it or some powder, some kind of juju that may affect her. We didn't know, we didn't have the knowledge that we have today. So it was difficult. You would serve her water and she wouldn't drink. We would do like some small party in the office, she wouldn't participate. So we were saying that this woman is difficult to live with, and we talked about it. Now, today, for instance, with the kind of knowledge we have received, it will help us to learn to live with these people. And I am grateful that this teachings today had been a blessing to us. Thank you very much. And Doctor, God bless you.
Amen. Thank you, Reverend.
Thank you. Thank you, Doc. Thank you, everybody who has shared with us today. Thank you, everyone who has joined us today. We want to keep everybody's time commitments in mind, so we are going to wrap up. But please note that our social media platforms have all been posted in the chat. So if there's anything you wanted to say during the session that you've not been able to say, or something that comes to mind after a question you want to ask Doc, please don't hesitate to reach out to us through those social media platforms, and we'll make sure that your questions reach the appropriate channels. Once again, thank you everyone for joining us. This session was made possible by the work of the Silent Scream Foundation, a non-profit organization in Ghana that works in the mental health space by working on issues of destigmatization and mental health access. If there's any information you need about mental health generally, how to access mental health resources, kindly visit any of the links that we've posted in the chat, reach out to us, and we'll provide that information to you. We want to thank Dr. once again for joining us today. We're very grateful to have her with her years of experience joining us and sharing all this information with us. Kindly note that if you would like to reach out to her, you can let us know, and we will let her get in touch with you. And we're very grateful to have had her today, had her time, had her experience. We'll have another session next month in January. We'll post all information about that on our social media channels as usual. So kindly stay tuned on those to have information and to join us. Please be reminded that these sessions are free, so you can join anytime. If you know anyone who would like to join as well, please share so that people will get to know and people have this information. And the session was also recorded. It's reposted on the YouTube. So as soon as it's uploaded, we'll let the link be available so that if you know anyone who would have liked to tune in but couldn't, can you share the link with them, and they'll be able to also get access to this information. So we're going to wrap up now. Thank you so much for spending your Saturday morning or afternoon, depending on where you are with us. We hope you have a lovely rest of your weekend and a good week next week as well. Thank you.
Thank you. Thank you. Bye.
Thank you.
Thank you, Doctor. God bless you.
Thank you very much. We appreciate you. Or maybe next time, please, if we can add more to the time so that we can, we are all benefiting from this, so that we have some, maybe some 15, 20 minutes. We sincerely appreciate it. Thank you very much. All the best.
Thank you.
Thank you very much, Doc. We are grateful for this opportunity.
Hello. Dr. Zachariah,
Hello, Doc.
are you still on?
Yes, please. I'm still here. Good
Oh,
morning.
okay.
Thank you for joining.
It's great. It's great. I like this.
Thank you
Today
so much.
I have received some information.
Thank you. I'm grateful. Thanks for joining.
I'll tell friends of mine and probably my psychology classmates
Oh, okay. Nice.
and give them the link so that they would
Join. Oh, thank you.
join. We have a platform. I'll put it there next time.
Thank
And
you.
let them join.
Thank you so much. Awesome. Thank you. I would appreciate that very much.
Amen.
God bless.
Bye-bye.
Bye.